Okay, let's kick things off. Today isn't just another deep dive. This is a mission. We are basically turning the studio into a final revision command center. If you're listening, you're probably a postgraduate student staring down the barrel of the Gujarat University MD Anesthesiology exams.
It's a feeling I remember well.
I'm sure. You got your stacks of Miller, Morgan, maybe some Stolting, and you have to somehow boil all of that down into a clear exam-passing answer.
And not just passing, but a high-scoring answer.
Exactly. And today, we're tackling a topic that is, well, it's absolute gold for the exams. It shows up everywhere.
It really does.
20-mark long answers, short notes, and it is a huge favorite in the Vivas because it forces you to connect everything, physiology, pharmacology, clinical judgment, all at once. We're talking about ERS.
Enhanced recovery after surgery.
So for today, think of yourself as our listeners' senior faculty mentor for this session. What's our mission here?
Our mission is to move beyond the checklist. I mean, any student can memorize a list of protocols,
Right.
but to get those top marks, and, more importantly, to be a safe and effective consultant down the line, you need to understand the why, the physiology behind every single step of the protocol. We're going to deconstruct ERS from the ground up with a very strict eye on what the examiners are looking for.
Perfect. So let's start right there. I'm in the exam hall. I've just opened the paper, and question 1 is discuss ERAs. How do I start? What's the definition?
You start strong. A confident, clear definition. ERS stands for Enhanced Recovery After Surgery. But don't stop there.
Okay.
You have to say it's a multimodal, multidisciplinary approach to the care of the surgical patient.
Multimodal and multidisciplinary. Those sound like keywords.
They're non-negotiable. You underline them in your mind. And you can add a little history for context, that it was pioneered by Henrik Kellett in the 90s, initially for colorectal surgery. But now, as Miller points out, it's used across almost every surgical specialty.
So what do those two words, multimodal and multidisciplinary, actually mean in this context?
Great question. Multimodal means we're using a whole bunch of different interventions together. It's not one magic drug. It's, a combination of regional anesthesia plus non-opioid painkillers plus a specific fluid strategy. They work together synergistically.
Okay, so the sum is greater than the part.
Precisely. And multidisciplinary means it's not just our show in the operating theater.
Right.
It involves the surgeon, the ward nurses, the dietitians, the physiotherapists. Everyone has to be on the same page.
And why is this topic so hot for examiners right now?
Because it represents a massive paradigm shift in our thinking. We used to talk about fast-track surgery.
I remember that term.
And that term implied speed, just getting the patient out the door. ERS isn't about speed. It's about the quality of the recovery.
Oh, okay.
It's about returning the patient to their normal physiological state as quickly but also as safely as possible. Examiners love it because it tests if you can connect your basic science knowledge to your clinical practice.
Okay, let's get into the meat of it then. The scientific basis. You said we need to understand the why. So, what is the fundamental problem that ERS is trying to solve?
The fundamental enemy, the big bad wolf of surgery, is the surgical stress response.
The stress response.
Yes.
Okay, this is deep in Morgan and Miller. It's the body's reaction to, well, the trauma of being cut open.
Exactly. I mean, think about it. When a surgeon makes an incision, it's a controlled trauma. But to the body, it's trauma nonetheless.
Right.
It triggers this huge neuroendocrine and inflammatory cascade. You get afferent neural signals screaming up the spinal cord to the hypothalamus.
Yeah, the hypothalamus is the command center.
It's the command center. And it panics. It pushes the button to release a flood of catabolic hormones.
The fight or flight ones.
The very same. Catecholamines, adrenaline, noradrenaline, cortisol, glucagon, growth hormone. All of these hormones are designed to break things down to provide energy for a crisis.
So the body starts breaking down its own reserves.
Precisely. And at the exact same time, it suppresses the anabolic or building hormones, things like insulin and testosterone.
So you've got this perfect storm of breaking down and not building up.
You're in a purely catabolic state. The body is mobilizing glucose like crazy, but here's the kicker, and this is a key point.
Right.
Because of all those stress hormones, the tissues, especially muscle and fat, become resistant to insulin.
So this is the famous insulin resistance.
This is the high-yield concept. You must talk about this. Miller emphasizes it heavily. Surgery induces a temporary state of insulin resistance that looks a lot like type 2 diabetes.
Wow.
And the size of that insulin resistance is directly proportional to the magnitude of the surgery. Bigger surgery, worse resistance. And it correlates with a longer hospital stay.
So for my exam answer, I need to basically highlight surgical stress response and insulin resistance as the two main physiological targets of ERs.
Highlight them, underline them, put a big star next to them. The entire goal of ERS is to dampen the stress response. We want to keep the patient in a fed and anabolic state, not a starved and catabolic one.
I've heard an analogy about this, something about a marathon runner.
It's a perfect analogy. Traditional surgery is like telling someone to run a marathon after you've starved them for 12 hours.
Okay.
And while they're running, you're shouting at them and throwing rocks. The body is starved from being NPO, it's stressed from the surgery itself, and it starts breaking down precious muscle for energy.
So what's ERS in this analogy?
ERS is the proper training and fueling strategy. We give them carbohydrates before the race, we keep them hydrated, we manage their pain so they can actually run the marathon efficiently and recover quickly.
That makes it so much clearer. And there's also the inflammatory side of it, right?
For that,
the cytokines?
Oh, yes, the cytokine storm. Tissue trauma releases inflammatory mediators like interleukin-6, IL-6, and TNF-alpha.
And they're what make you feel sick after surgery.
Exactly. The fever, the fatigue, the general feeling of malaise. Many areas interventions like minimally invasive surgery and especially regional anesthesia are designed to blunt this cytokine release.
Okay, so we've nailed the physiology. Dampen stress, reduce insulin resistance, minimize inflammation. Now let's build on that with the core principles. Miller mentions a concept called the aggregation of marginal gains. What's that about?
It's a fascinating idea, actually borrowed from professional cycling.
Oh, interesting.
The idea is that there's no single magic bullet that transforms recovery. It's not about finding one perfect drug.
Right.
It's about making dozens of small 1% improvements in many different areas. Maybe keeping a patient warm only improves outcomes by 2%.
Okay.
And maybe good pre-op counseling improves it by 3%, and early feeding by 5%. Individually, they're small gains.
But when you add them all up?
When you aggregate all those marginal gains, you get a massive synergistic improvement in the patient's overall recovery.
So it's the system that works, not any single intervention.
That is the core message. And that brings us right back to that word, multidisciplinary. You, as the anesthesiologist, cannot do this alone.
Right.
You could provide a flawless epidural, but if the surgeon leaves drains in for a week and the nurse doesn't mobilize the patient, the whole system fails.
And what about this idea of audit and compliance? Why is that a core principle?
Because you cannot improve what you do not measure. It's crucial for the exam. Compliance with the protocol, actually doing all the steps, is the single strongest predictor of success.
So you need to track your data.
You need to audit your results. What's your length of stay? What are your complication rates, your readmission rates? You use that data to prove the system is working and to find areas for improvement.
Okay, let's break down the protocol itself chronologically. This seems like the best way for a student to structure their long answer. Pre-op, intra-op, post-op.
Absolutely. Structure is everything in an exam. You start with preoperative.
Right, preoperative components. We usually think of this as just, a quick checkup, but ERAS really expands this phase. Let's start with pre-admission counseling.
It sounds like a soft skill, but the science behind it is hard.
How so?
Simply put, reducing a patient's anxiety reduces their stress response. If a patient knows exactly what to expect,
like what?
like, okay, you will wake up with some tubes, you will have some pain, but we will be on top of it. And our goal is to get you sitting in a chair on the very first day. When they know that, their need for painkillers actually goes down. It sets the expectation for active recovery.
Okay, and now for the big one. The one that still feels counterintuitive because it goes against everything we were taught for decades. Fasting guidelines.
The dogma of NPO after midnight,
Yes.
it needs to be retired. Permanently.
So what are the current guidelines we absolutely have to quote in the exam?
You have to quote the current ASA and ERS Society guidelines. It's simple. Clear fluids are permitted up to 2 hours before the induction of anesthesia.
2 hours.
And for solids or non-human milk, it's 6 hours.
And we're not just letting them drink water, are we? We're actively giving them something. This, carbohydrate loading.
This is a massive paradigm shift. We give a specific, complex carbohydrate drink, usually containing maltodextrin, about 2 to 3 hours before surgery.
Okay, wait. So you're giving a patient a sugary drink right before putting them to sleep for surgery. Why?
Go back to the physiology we just discussed. If you starve a patient overnight, they show up to the operating room already in a catabolic state.
Right. Their glycogen stores are depleted.
They're completely depleted. Their body is already breaking down muscle proteolysis to find fuel. By giving that carbohydrate load, we essentially trick the body. It triggers a small, helpful release of their own endogenous insulin.
So we're flipping the metabolic switch from fasted to fed.
Exactly. We shift them from a catabolic to an anabolic state just before the surgical insult hits. The data is incredible. It can reduce postoperative insulin resistance by up to 50%.
50%, that's huge.
It is. It preserves muscle mass. And just on a human level, it improves patient comfort. They aren't arriving in the OT feeling thirsty, hungry, and irritable.
That is a Viva winning point right there. It shifts the metabolism from catabolic to anabolic.
Definitely. And don't forget the other preoperative pillars. Smoking and alcohol cessation, ideally 4 weeks prior. Correction of anemia. Miller is very big on patient blood management. And nutritional assessment. Look at their albumin levels. A malnourished patient is a huge risk for infection and anastomotic leaks. You might even delay elective surgery to build them up nutritionally.
Okay, let's move into the theater. Intraoperative components. This is our domain. What's the anesthetic technique for ERAS?
The philosophy is rapid emergence with a minimal hangover effect.
Yeah.
So short-acting agents are king. Propofol, remifentanil, desflurane. We want the patient awake, breathing comfortably and coherent as soon as the drapes come down.
And what about regional anesthesia? You called it the anesthesiologist's superpower?
It truly is. For major open abdominal or thoracic surgery, the thoracic epidural is still considered the gold standard in many, many ERAS protocols.
What makes the epidural so special in this context? It's not just pain relief, is it?
It's so much more than pain relief. The magic is in the sympathetic blockade. The epidural literally blocks the afferent pain signals from the surgical site from ever reaching the brain.
So it's like cutting the phone line.
You've cut the line. The brain doesn't fully perceive the scale of the trauma that's happening, and this directly blunts that whole neuroendocrine stress response we talked about.
Meaning less cortisol, fewer catecholamines.
Precisely. And there are other benefits. By blocking the sympathetic outflow to the gut, it helps prevent that dreaded postoperative ileus. The gut keeps moving. And of course, it provides absolutely superior pain relief without the side effects of systemic opioids.
Let's talk about another controversial topic. Fluid management. The whole wet versus dry debate.
The pendulum has really swung back and forth on this one. We used to drown patients in crystalloids.
Right. The third space theory.
Which has been largely debunked. Then we went too far the other way and kept them too dry. The modern answer, the ERAS answer, is goal-directed fluid therapy, or GDFT.
I've heard the phrase keep them euvolemic, or dry but not dehydrated.
That's the essence of it. Look, excessive crystalloids mean the patient retains salt and water. This causes edema everywhere, but especially in the gut. A swollen gut doesn't work. That's ileus.
And that delays recovery.
Massively. But on the other hand, hypovolemia is dangerous. It leads to organ hypoperfusion. So we use technology things like stroke volume variation, or SVV from an arterial line, or an esophageal Doppler to guide us. We give small fluid boluses only when the patient shows they need it to maintain their stroke volume. The goal is zero balance by the end of the case.
And temperature control, how important is that?
Oh, it's non-negotiable. You must maintain normothermia. Hypothermia is a complete disaster for the surgical patient. It triggers the stress response all on its own. It causes coagulopathy, so they bleed more. And it significantly increases the rate of surgical site infections. You must be actively warming every patient with forced air blankets and fluid warmers.
And what about PONV?
Postoperative nausea and vomiting. It's a huge enemy of ERS. If a patient is vomiting, they can't drink or eat.
And they stay catabolic.
Exactly. So our approach has to be prophylactic, not reactive. We use a multimodal approach from the start, a 5-HT3 antagonist like ondansetron plus dexamethasone, and maybe even using Tiva instead of volatile gas if they're high risk.
Okay, let's move into recovery and the ward. Postoperative components.
Yeah.
The surgery is over. In the old days, the patient would just lie in bed for days.
And they'd get a DVT, muscle wasting, and probably a chest infection.
Right.
The new way is early mobilization. We want them out of bed, sitting in a chair on day 0 or day 1.
Why is getting up and moving so critical from a physiological standpoint?
Well, for one, it prevents muscle atrophy. It dramatically improves insulin sensitivity exercise, helps muscles suck up glucose from the blood, it improves lung function, and honestly, it provides a huge psychological boost to the patient.
And what about feeding them?
Early enteral nutrition. Another dogma we had to kill was wait for bowel sounds.
Right. You wait for a fart or a rumble.
We now know that's a myth. We don't need to wait. We can give them clear fluids or even chewing gum almost immediately after surgery.
Chewing gum? Really?
Yes, it's called sham feeding. The act of chewing stimulates the cephalic phase of digestion. It gets the gut hormones and juices flowing and actually reduces the time to first flatus. Feeding the gut early maintains the integrity of the mucosal barrier, preventing bacterial translocation. It actually reduces ileus.
That's fascinating. Now, pain. We touched on opioid sparing. Why the sudden war on opioids in ERS?
Look, opioids are powerful painkillers, no doubt, but their side effect profile is a complete enemy of enhanced recovery.
Oh, so.
They cause sedation, so the patient can't mobilize. They cause nausea and vomiting, so they can't eat. And most critically, they paralyze the gut. Opioid-induced bowel dysfunction is a major cause of ileus.
So what's the alternative?
Multimodal analgesia. We attack the pain from multiple angles using different receptors. We use a baseline of paracetamol and an NSAID if there's no contraindication.
Okay.
On top of that, we can use low-dose ketamine infusions, magnesium, lidocaine infusions, and of course, our regional blocks. By combining all of these, we can massively reduce or sometimes even eliminate the need for morphine.
And the last piece of the post-op puzzle. Drains and tubes.
My philosophy is simple. Drains are a tether. They physically and psychologically anchor a patient to the bed.
Right.
ERAS dictates that we remove urinary catheters, NG tubes, and surgical drains as early as humanly possible. We don't put them in just in case anymore.
This all leads perfectly into a crucial section for the exam, the specific role of the anesthesiologist in all this.
This is where you can really shine in your answer. You have to reframe your role. You are not just the gas man or a technician who is present for just the surgery.
So what are we?
In the ERAS model, the anesthesiologist is the perioperative physician. We are the leaders, or at least the key coordinators, of what's called the perioperative surgical home, the PSH.
I like that. The perioperative surgical home. It sounds comprehensive.
It is. It's a model of care where we oversee the patient's entire journey, from the moment the decision to operate is made, all the way through to discharge and beyond.
So our responsibilities include?
Preoperative risk stratification and optimization, intraoperative physiological management of fluids, temperature, and anesthetic depth, and crucially, postoperative management of pain via the acute pain service. We are the linchpin holding the pre-op, intra-op, and post-op phases together.
If an examiner asks me, what are the proven benefits of ERAs? What are the hard numbers I should quote?
You need to have this data ready. Number 1, reduced length of hospital stay, or LOS, typically by 2 to 3 days.
That's significant.
It's huge. Number 2, a reduction in overall postoperative complications by 30 to 50%.
30 to 50, that's massive.
It's a game changer. And from those 2 points, you get cost effectiveness. Fewer complications and shorter stays save the healthcare system a lot of money. And finally, improved patient satisfaction and a faster return to normal life.
We've talked a lot about colorectal surgery, which is where ERS was born. How does it apply to other specialties? Just briefly.
You should be able to give a few examples. For liver resection, a key ERS component is fluid restriction, specifically during low resection phase to lower the CVP and reduce bleeding.
Okay.
For thoracic surgery, early and aggressive mobilization and physiotherapy are absolutely critical to prevent pneumonia and atelectasis. In urology, especially a major surgery like a cystectomy where they use a piece of bowel for urinary diversion, preventing ileus becomes the #1 priority, so all the gut-related protocols are key.
It sounds perfect, but it can't be that easy. What are the real-world challenges and limitations?
The single biggest barrier is institutional culture. It's the phrase, "but we've always done it this way."
The inertia.
Exactly. Getting a surgeon who has starved patients for 20 years to suddenly be okay with the carbohydrate drink 2 hours before surgery can be a real battle. The other major challenge is compliance.
Right. Getting the whole team to stick to the plan.
Yes, yeah. It requires constant education and buy-in from nursing, surgery, physio, everyone. If one link in that chain breaks, the protocol's effectiveness drops significantly. And sometimes there are patient factors, like low health literacy or lack of social support for an early discharge.
So where is this all heading? What are the future directions in enhanced recovery?
Well, we mentioned the perioperative surgical home. That's the big organizational future. Clinically, the next frontier is prehabilitation.
Prehabilitation, so habilitation before the surgery.
Precisely. It's about training the patient before the surgical insult, putting them on an exercise program, giving them nutritional supplements, psychological support, all to increase their functional reserve so they can withstand the stress of surgery even better.
And technology.
Wearable technology is going to be big. using smart watches and apps to monitor a patient's mobilization, their sleep patterns, and even their vital signs after they've been discharged home.
Okay, we're coming into the final stretch. This is super high yield. Common exam questions and Viva traps. Where do students typically go wrong and lose marks?
The biggest trap, by far, is what I call the list trap. The examiner asks about ERS, and the student just recites a memorized list. Feed early, mobilize early, use short-acting drugs.
Which gets you a pass, but not a distinction.
Exactly. It shows you memorize, but you don't understand. To get the top marks, you must link every single step back to the physiology. Don't just say, I will give a carbohydrate drink. You say, I will administer a preoperative carbohydrate load in order to reduce postoperative insulin resistance and maintain the patient in an anabolic state. See the difference?
The because. Always explain the because.
Always. Another Viva trap is the regional versus general debate. They might push you on it. They might ask, so does an epidural completely abolish the surgical stress response?
Ooh, that's a tricky question. Does it?
And the nuanced, high-scoring answer is, it significantly attenuates or blunts the response, especially for surgery on the lower body. But it may not completely abolish it, particularly in major upper abdominal or thoracic surgery, because there are still other pathways, like vagal afferents and circulating inflammatory mediators, that aren't blocked by the epidural.
That's a great answer. What about fluids?
They will grill you on fluids. Be ready to explain the difference between zero balance and goal-directed. Zero balance is the desired outcome. Goal-directed therapy is the method you use to get there safely while always ensuring you're maintaining adequate tissue perfusion.
Okay, let's talk about presentation. For that 20 marks long answer, how do I make my paper stand out?
You have to remember, the examiner is tired. They've read dozens of scripts. Make yours easy and pleasant to read. Use visuals.
Like what?
Draw a simple flowchart, a timeline. Draw a line across the page and label it. Home pre-op clinic management recovery ward hem home. Then, plot the key ERS interventions along that timeline. It shows you understand the whole patient journey.
That's a brilliant tip.
And use a comparison table. It's so powerful. Make 2 columns, traditional care versus ERS protocol.
So, for example?
Column A, NPO from midnight. Column B, carbohydrate loading 2 hours pre-op. Column A, reactive opioid analgesia. Column B, prophylactic multimodal analgesia. It shows the contrast immediately and proves you understand the paradigm shift.
Fantastic. Okay, let's wrap this all up with a final summary. Give us the elevator pitch for the examiner when they ask you to conclude.
Okay. ERS is not about speed. It is about restoring normal physiology. It is an evidence-based, multimodal, and multidisciplinary approach aimed at fundamentally dampening the surgical stress response, reducing insulin resistance, and keeping the patient in a functional anabolic state.
Nice.
It is proven to reduce complications, shorten hospital stays, and improve patient satisfaction. And in this entire process, the anesthesiologist is not a passive participant. We are the central perioperative physician who leads and coordinates this journey.
That is a powerful conclusion.
And remember, for your exam, if you get lost, just go back to the science. If you truly understand the physiology, the stress response, the insulin resistance, the cytokine storm, you can reason your way through any question they throw at you.
Fantastic. To our listener, our postgraduate student getting ready for this exam, you've got this. Take these concepts, visualize that flowchart and that comparison table, and always remember the why. Go in there and show them you're a thinking physician, not just a protocol follower.
Best of luck. Review those key diagrams in Miller, especially the ERAS timeline. You'll do great.
That's it for our deep dive on ERAS. Now, go and ace that exam.